Hello students, myself Dr. Saramma Mathew, Associate Professor from the Department of Oral Medicine and Radiology, Vinayaga Missions, Shankaracharya Dental College. Today's lecture topic will be on bisecting angle technique. So to begin with, bisecting angle technique was developed by Weston Price in the year 1904. There are various names for this bisecting angle technique, such as bisection of the angle technique. It's also known as short cone technique. In this technique, word bisecting angle depends that the film is kept near the teeth and the X-ray beam is focused to the bisecting line of film and the tooth. Where this bisecting angle technique is utilized is while taking radiographs. In dentistry, we take two types of radiographs, that is intraoral and extraoral radiographs. In intraoral means we are keeping the receptor or the dental film inside the oral cavity and we take radiographs. Whereas in extraoral, the film or the image receptor is placed outside the oral cavity. So in the intraoral taking radiographs, we commonly use bisecting angle technique as well as paralleling angle technique. So today's intraoral radiograph, we are going to deal with bisecting angle technique in this lecture. So this intraoral radiographs, we have periapical view, we have bite wing view, we have occlusal view. So mainly for taking periapical radiograph, that is 3 to 4 millimeter below the apex of the root portion is covered in the periapical radiograph. For this periapical radiograph, we intend to take with the technique called as bisecting angle technique. So in radiograph, what do we see? We have to convert the 3D anatomical landmark into a 2D picture in a simple plane. So all the anatomical structures which is in 3D format has to be covered in a 2D plane form for visualization for the anatomical landmarks as well as for the diagnosis. So to achieve this 3D dimension into a 2D plane, we require certain techniques. That is what is known as, we use the technique called as bisecting angle technique. So moving to the principle of this bisecting angle technique is, it works on the simple theorem known as Ziesecke's rule of isometry. So what is this isometry means? Means that the two triangles should be, the angles should be at equal, the sides should be equal. So how do we achieve these two triangles in the oral cavity is challenging. So that is what this technique has multiple angulations and the angle formed will be the same. So in simple terms, the two triangles are equal if the two equal angles and they share the common side, that is the hypotenuse side, to avoid the magnification. This is one triangle, this is the other triangle. So these two triangles which is formed while taking a radiograph should be equal, then you get a perfect image. So this is the hypotenuse line which divides the two triangles, and this hypotenuse line will be equal and which will split the two triangles. So these are all imaginary planes which we have to assume while taking radiographs. While going to the principle again, this is this X-ray head through which the central beam or X-rays will fall onto the tooth. Say the tooth which has to be taken using radiograph, the image receptor will be placed as close to the tooth as possible in the bisecting angle technique. When the central beam falls onto the tooth, the imaginary lines are formed, that is the two triangles are formed. The first triangle will have, which is denoted by A, will have the long axis of the tooth on one side and the other side will be the hypotenuse line which completes one triangle. For the second triangle, the one side will be the hypotenuse side and the other side of the triangle will be the X-ray film, and the base will be, for both these triangles, will be the tip of the long axis of the tooth. So the angle formed which will be congruent in this bisecting angle technique. So these two triangles are the basic principle which, if these two triangles are equal in length, equal in both the sides, and the hypotenuse divides and forms an acute or a congruent angle, then we call that to be a bisecting angle technique. So again, the two triangles are equal only when the central beam is directed perpendicular to an imaginary bisector that bisects the angle formed by the long axis of the tooth and the film. So the central ray always has to be formed onto the imaginary bisector which divides the two triangle. So that should be perpendicular in case of bisecting angle technique. This covers the principle of Zizenki's rule of isometry. So thereby we achieve this equal angle triangles imaginarily by keeping the patient positioning exactly as indicated, and by giving the correct vertical angulation we achieve this Zizenki's rule of isometry. Thereby we can reproduce the 3D image into a 2D image to the exact same size. So now what are the steps in taking radiographs? For a radiograph to be taken, there should be proper positioning of the patient, then the area of interest or the target area to be evaluated before placing the image receptor. After which, once the area of interest is decided, the image receptor is held onto the oral cavity either by the film holders or by the finger holding method. Then the image receptor is placed as close to the tooth to be examined, and provided the tooth of interest is supposed to be in the middle of the receptor, which will cover the entire area so that the central beam falls exactly onto the bisector which has to be taken. Then the next step is the proper head orientation, and the PID device, that is the central beam passes through the position indicating device, and that tube head has to be placed correctly to achieve the vertical and horizontal angulation in this technique. Then we have to take care of the point of entry of the X-ray beam. Once we follow all the steps, then we have to proceed to the exposure. So first step we'll go in detail, but this the patient head orientation. So the patient's head is positioned for the arches, be it maxilla or mandible. The radiograph is placed inside the oral cavity, and the patient's head is positioned in such a way that the arches are always parallel to the floor and the mid-sagittal plane is perpendicular to the floor. So for the maxillary projection, the alar tragus line to be parallel to the floor, which is achieved by tilting the head slightly downwards, and for the mandibular projection the line is about 1 centimeter above the lower border of the mandible and should be parallel to the floor, and the head is tilted slightly upward. This is the picture which depicts that the mid-sagittal plane is shown here, that is in the mid of the radiograph to be taken. This is again the mid-sagittal plane, and this is the alar tragus line, that is the line, these are all imaginary lines which runs from the tip of the nose to the tragus of the ear. So this line should be parallel to the floor while taking radiographs. Now the maxillary projection, I had told you that the alar tragus line should be parallel and the head is tilted downward so that the PID will fall onto the maxillary projection, which is indicated in a positive angulation. Whereas for mandible, this is the PID through which the central beam passes. For the PID should be placed in 1 centimeter above the lower of the mandible so that we get negative vertical angulation. So this vertical angulation will determine the radiographs in accurate positioning. So to acquire all these images, we need image receptor. So the image receptor is commonly known as the dental X-ray film, which is held inside the oral cavity for a bisecting angle technique using the holders. So one such holder is called as the snap array X-ray holders, and other way is the stable bite blocks. So these are the two instruments or devices required to place the film inside this abrasions so that it is stably placed inside the oral cavity. So moving to the horizontal angulation, for the bisecting angle technique there are two angulations required. One is horizontal angulation, another one is vertical angulation. So first is the horizontal angulation. So what does it mean with horizontal angulation is that when the central beam passes through the maxillary arch or mandibular arch, the PID is parallel to the buccal surface of the teeth. That is, the central beam should be parallel to the buccal surface of the teeth so that the image receptors are parallel to the floor. then it is called as the horizontal angulation, and usually the horizontal angulation is considered to be 0 for bisecting angle technique, so that the X-rays will be perpendicular to the film. So this is the horizontal angulation, which is always tend to be 0 degree. Then is the vertical angulation. Since we have the curvature of the maxillary and mandibular arch, the film has to be placed in such a way so that we give a vertical angulation in such degrees so that we acquire for each teeth has different angulation. For a maxillary teeth, the incisors will be 10 from plus 50. As I said, the PID is shifted in the previous diagram, that the PID is, the head is tilted downwards, so that we get the plus angulation, that is positive angulation. For us mandibular teeth, the angulations are represented by negative angulations. So for incisors, maxillary central incisors or lateral incisors, the angulation for maxillary teeth is denoted with plus 50 degree, whereas for mandibular incisors it is minus 20 degree. For canine it is plus 45, and for mandibular canine it is minus 15 degrees. The premolars it is plus 30 degree, and for mandibular premolars it is minus 10 degree, and the molars will be plus 25 degree for maxillary, and for molars in the mandible it will be minus 5 degree. So this vertical angulation is constant, and it is already prefabricated in the calibrated in the machines. So once before taking radiograph, we can calibrate the positioning of the PID and focus on to the area of interest. Now moving to the point of entry of central beam for a maxilla. We read that the angulations, vertical angulations are required. We fix the angulation plus 50 plus 45. So where do you actually, the central beam is focused? We need to know the few landmarks, anatomical landmarks, where the central beam or plus 50 degree is achieved in case of central incisor maxillary. So that is called as the point of entry of central beam. For a maxillary projections in the central incisor, when we say the vertical angulation is plus 50 degree, where does the area represent is? The area intersecting the alar tragal line and the vertical line, that is the mid-sagittal line, both these lines will intersect at the tip of the nose. So when we place the PID for central incisor with plus 50 degree represents the tip of nose for a central incisor radiograph. Then similarly for lateral incisor, again it is the alar tragal line which should be parallel to the floor, and this angulation or the angle of plus 45 degree or plus 50 degree is achieved by an imaginary line which intersects the alar tragal line and the mid-sagittal line, which passes 1 centimeter lateral to the tip of the nose for a lateral incisor projection. For a canine, maxillary canine projection, the angulation was plus 45 degree, which is achieved again by the alar tragal line being parallel to the floor and the mid-sagittal plane. These two lines, imaginary lines, will intersect at the point near the center of pupil. So these are the landmarks which will help you or guide you to place the films inside the oral cavity, and you can position the PID at this level so that we achieve the vertical angulation and horizontal angulation so that we get a radiograph without error. Now for the first and second premolars, again the alar tragal line and the vertical line will exactly coincide at the center of the pupil. For the molars, again the lines will intersect at the outer canthus of the eye. So that is what the PID will be moving backwards for the maxillary molar projections. Then again to the third molar, the area intersecting the alar tragal line and the vertical line from 1 centimeter distal to the outer canthus will be the point of central beam or point of entry of the central beam. By knowing these landmarks, we will be able to achieve a good radiograph. Now coming to the point of entry of the central beam for the mandibular projection will be again the central incisor will be the horizontal line from 1 centimeter above the lower border of the mandible and the vertical line from the tip of the nose in the chin area. So similar way we get for the lateral incisor, this will be the lower border of the mandible will be considered as the anatomical line or imaginary line, and then the mid-sagittal plane will intersect at one point which is 1 centimeter above the border of the mandible, and it will be lateral to the tip of the nose. Similarly, for canine, it is the line intersecting at this point, that is in the inner canthus, will be the landmark for the canine mandibular projection. For premolars, again, intersecting point will be at the lower border of the mandible and the vertical line from the center of the pupil. For the third molars, this will be the intersecting line from 1 centimeter above the lower border of the mandible and the vertical line 1 centimeter to the distal to the outer canthus. So these are the similar ways of projections we do. So we have seen the vertical angulation, we have seen the horizontal angulations. So if in case the commonest error or faulty radiographs in a bisecting angle technique, the common error is two main errors are seen. One is the image foreshortening, another one is the elongation of the image. So for the first picture will tell you the radiograph looks images foreshortened, which means the vertical angulation which we have learned throughout has kept being placed too large. That is, the film is tilted more backwards. So when the vertical angulation between the tooth and the image film is larger, then we get the foreshortening as the error. That is, the image will be shortened from the actual size. So that is called as foreshortening, which happens when the vertical angulation, that is the angulation which is formed when the bisector falls onto the midplane, is larger. Then we get the errored radiograph as foreshortened. Similar way, we get another error called as image elongation, which happens when the vertical angulation has become too small. That is, the receptor is kept as close to the possibility of the tooth image, whereas the image becomes, the vertical angulation becomes too small, so that the image will be too long, which is not helpful for any diagnostic process. So when there is vertical angulation, if it becomes too small, the image will become too long. So it is actually inversely proportional to the bisector line. So these are the two commonest error which occurs in the bisecting angle technique. Now what will be the advantage of using a bisecting angle technique is the positioning of the image receptor is comfortable for the patient, because the patient, he or himself, will be holding the image receptor in the oral cavity, or the bite block is too easy to be placed inside the oral cavity, which is, and the procedure is relatively simple and quick if you place the correct angulations. Once we get the vertical and the horizontal angulation in a proper way, we get an exact image, and the film will be easily adapted to the dental arch, and more teeth you can accompany it in a single film without overlapping. When the horizontal angulation is improper, the error of overlapping occurs, so which can be avoided if the horizontal angulation is 0 degree. So these are the advantages of using a proper angulations. If we assess with the help of the anatomical landmarks, we get the exact length of the teeth, which can be reproduced in an image receptor. There are certain disadvantages, which I said, the faulty errors which occurs, or faulty radiographs which occurs if the angulations are not proper. Say if the horizontal angulation is incorrect, it results in overlapping of the crowns and roots. Then if there is incorrect vertical angulation, say too large, it results in image foreshortening. If there is incorrect vertical angulation, if it is too small, it results in image elongation. And if the PID is not positioned into the central ray, if it is not achieved in the exact position of the image receptor, then there is an error called as cone cutting. So the PID's back, it's not placed parallelly to the tooth surface. So that is one error. And then the periodontal bone levels are not assumed or achieved properly in some cases if the angulation goes wrong. And always the buccal roots of maxillary premolars and molars are always foreshortened when we use this technique. So these are the common disadvantages of using a bisecting angle technique. To conclude, it is better always to practice the bisecting angle technique to achieve a perfect radiograph for diagnostic purpose. Thank you for listening.